So my name is Zach Daly, and I'm from the University of Utah at the Center for Mindfulness and Integrative Health Intervention Development. And my talk is on moving past the current psychedelic model of therapy for substance use disorder. So here are the topics I'll be discussing today. First, I'll operationalize the definitions of opiate use disorder and substance use disorder. Then I'll go into how the cycle of addiction traps a person into using opioids. Then I'll talk about the prevalence and risks of opiate use, the current treatments for opiate use disorder, the current psychedelic research paradigm and benefits and limitations of the current paradigm. Then I'll talk about the ways in which we can turn the knobs or variables to boost the treatment efficacy of psychedelic assisted therapy for opiate use disorder. And then I'll be discussing the current relevant studies. And lastly, I'll be talking about the potential directions for future research. So first off, what is substance use disorder and what is opiate use disorder? So defined by the DSM, substance use disorder is the recurrent use of a substance that causes impairment to one's physical health and cognition and leads to the failure to meet work, school, and household needs. Now, there's a caveat to this that we have to make sure to understand. There's actually a cultural component to substance use disorder. So for instance, I'm from Wisconsin, and if you see that darkest part of the map for people who binge drink in the past 30 days, Wisconsin the darkest. And generally people might have a pint of beer after work with their friends. Drinking's acceptable, it's pretty normal. But where I'm currently working in Utah, drinking isn't as socially acceptable. The drinking limit's 0.05 instead of the nationwide 0.08, and drinking could lead to legal and social issues more easily than Wisconsin. So that's just something we should note. Opiate use disorder is then a specific type of substance use disorder, and opiate use disorder is often comorbid with chronic pain conditions. So now let's get into the cycle of addiction. So prolonged opiate use leads to an increase in tolerance and escalation of dose to achieve the same effect. Chronic opiate use then leads to impulsivity and impairment to working memory and a reduced cognitive flexibility. Chronic use also leads to hyperanalgesia, which is defined as an increased responsiveness to painful stimuli. Furthermore, opiate use leads to a downward spiral of negative affect, where one experiences reduced response to natural rewards, like eating a good meal or seeing the sunset, and an increased responsiveness to drug cues. This leaves one unable to experience pleasure without using opioids, and combined with withdrawal symptoms, all of this leads to the cycle of opioid addiction. Now let's go over the prevalence and statistics. So it's estimated that 6.7 to 7.6 million Americans with experience OUD. And research shows that opioid overdose deaths are increasing year after year, as you can see in the statistic from the CDC. And very striking, males significantly experience overdose deaths than females at double the rate. So now let's get into current medication-assisted treatments. So current medication-assisted treatments are buprenorphine, methadone, naltrexone, and Suboxone. Buprenorphine is a partial opioid agonist that binds to the mu opioid receptors. It has what is called a ceiling effect. So where after a certain dose, the person is unable to feel any more effect. Buprenorphine comes in a injection form called Sublocade, where when someone's injected with this jelly-like substance, it slowly releases over the course of a month. Then with methadone, it's a full opioid agonist. It's seen as the gold standard, and it's easily more tolerated than buprenorphine. Next is naltrexone. It's a opioid receptor antagonist, so it binds to the opioid receptors and then blocks activation. So if one were to take heroin or fentanyl, it wouldn't cause any high. And then lastly is Suboxone, which is a combination of buprenorphine, naloxone, which is the medication used for opioid overdose. And this was specifically formulated to stop abuse because if one takes it orally, it'll have a therapeutic effect, as the naloxone doesn't absorb sublingually. However, if someone were to take their dose and then inject it, then the naloxone would block the activation and cause a person to go into precipitated withdrawals. Now, there's also psychotherapies, support groups, and rehabs. Cognitive behavioral therapy, otherwise CBT, is seen as the gold standard. You also have mindfulness-based cognitive therapy, which is a marriage between CBT and then mindfulness-based therapies like MBSR. Next, you have mindfulness-based relapse prevention, which is specific for addiction relapse prevention. And then lastly is mindfulness-oriented recovery enhancement, which tackles both chronic pain conditions and substance use disorder, which is both seen in OUD populations. Furthermore, you have support groups like Narcotics Anonymous. This can help a lot of people. However, some people don't like it due to the religious elements that are inherent in the approach. And then lastly is rehab. So there's a lot of different forms of rehab, both inpatient versions and outpatient versions. It integrates medication-assisted treatments with psychotherapy and support group and skill building. However, it can be hard to translate these to the real world because people often relapse due to the lack of opportunity and social support once they get out. So now we'll get into the basic psychedelic therapy structure. So it was first started up by Dr. Roland Griffiths and the team at JHU in 2006. It involves generally, this is based off this study, but this is kind of what generally goes on in the research. 8 hours of rapport building with the therapist, or with the therapist and the participants, going over their life history, making sure that they're comfortable going into the session. Expectancy is then developed in the actual session. So the therapists want the participants to be able to focus on the specific issues in their sessions. Participants are then dosed in a comfortable room with classical music or other music and lay on a couch with eye shades on. And then following that, there's generally like 4 hours of integration after each dosing session. However, these lack specific treatment modalities. So there's no CBT or more integrated into this. And there's a lack of interaction during the drug dosing sessions unless maybe the participant needs support or something like that. And here is a quintessential picture of Mary Cosimano, someone else, and then they're in the Johns Hopkins dosing room. So next, I'm going to discuss the benefits and limitations to this approach. So the benefits are that it allows for rapport building with the participant, to be comfortable with the therapist. There's enough support for a reliably safe experience. And there's this building of expectancy, so focusing on whatever is, in the research question. And then lastly is there is a limit of therapeutic intervention before, during, and after the dosing, which allows for limitation in variables so that you can find causal data. However, there's also some limitations to this approach, which is that it's designed for answering research questions and not maximizing therapeutic outcomes. And this leads to lacking a holistic approach like integration of other therapies, interaction during the session, and interaction to bring insights back to the real world during the integration. So next, we should really be looking at tweaking the model of psychedelic therapy for OUD. And this could involve, one, adding medication-assisted therapies like buprenorphine, methadone, or naltrexone to psychedelic therapy. Two, could be integrating already clinically validated multi-week psychotherapeutic interventions such as CBT, MBCT, or more. Three, could be teaching mindfulness meditation before, during, or after the psychedelic therapy to maybe boost some of the effects. Four, could be a greater therapeutic presence of the therapist to work with the patient and potentially a reduction in dose, similar to how it was done in the 60s or 70s with Humphrey Osmond, where he gave them a medium dose and they actually talk through their issues in the dosing session. And then lastly, could be an increased integration, social support to kind of bring it back to the real world. So now I'll be talking about essentially what's being done to tweak these different variables and turn the knobs of the therapy. So there are two studies that were done out of Switzerland with Smigelski and Dr. Franz Vollenweider, and the participants participated in a 5-week meditation retreat and were either randomized to receive a psilocybin dose or a lactose placebo. So here are some quotes from each of the studies and what they were found. So the study psilocybin-assisted mindfulness training, they found a decoupling of medial prefrontal and posterior cingulate cortices, which is thought to mediate sense of self, and was associated with subjective ego dissolution during the psilocybin-assisted mindfulness session. And then their other study, the characterization and prediction of acute sustained responses to psychedelic psilocybin in mindfulness group retreat, they found that psilocybin increased the meditation depth and the incidence of positively experienced ego dissolution, along with a lack of anxiety during the session. And while these, they found these effects, these are just something that we'd expect generally, given the plethora of research that was already done. And however, there was a lack of any research really looking into psilocybin plus mindfulness training versus psilocybin alone to see if can mindfulness training actually increase the therapeutic potential of psilocybin. So a lot of studies aren't being done or are currently being done or not finished. And we have an awesome study that's being done by Dr. Rael Khan out of USC, who's doing just this and answering this question. So there's currently a study that's starting this summer that's going to investigate psilocybin plus an 8-week mindfulness training versus mindfulness training alone. This study does not deal with substance use disorder, opiate use disorder, but it would be interesting to see what the findings are and potentially translating it to substance use disorder and opiate use disorder. So now we'll get on to current studies that are being done with medication-assisted treatments and psychedelic-assisted therapy. So there is a study being done by UW-Madison, specifically for opiate use disorder. It's an open-label pilot study that's seeking to introduce participants to Suboxone before giving them a psychedelic dose. They'll complete 6 hours of prep work with a therapist, a dosing session, an integration session, and then a second dosing session 4 weeks later, followed by more integration. There's no mention of what the counseling entails, but I assume it's going to be similar to the current rapport building models that are already out there. And now there's also another study being done by the folks at the Center for Psychedelic and Conscious Research at JHU that's investigating a randomized, double-blind, placebo-controlled study where participants are undergoing an outpatient treatment with buprenorphine, and they'll either receive the psychedelic therapy or placebo. Next is a ketamine-assisted mindfulness study that's actually being done at our lab. It was just completed at the University of Utah. The study was extremely novel because instead of just focusing on adding medication-assisted therapies to maybe a ketamine-assisted therapy protocol, we actually had participants undergo our 8-week MORE intervention. So it was a blinded study where we recruited participants who were already receiving a medication-assisted therapy that included buprenorphine in the formulation. So it could have been buprenorphine, Sublocade, or Suboxone. They were randomized to either receive our MORE therapy or MORE plus ketamine-assisted psychotherapy, and the session was slotted halfway through the 8-week intervention. The study involved qualitative data, a lot of questionnaires, objective EEG measures, and other psychophys pre and post. And we're currently processing the data and we'll be publishing the research shortly. However, in the meantime, you can check out the clinicaltrials.gov page if you're interested in learning more about what we did. Lastly, I'm going to be discussing some of the potential directions that we could go in the future for substance use disorder and specifically opiate use disorder studies. One could be looking at the presence of a therapist with a medium dose and actually having the therapist potentially administering a therapy during the session versus no therapeutic intervention during the dosing session, kind of trying to see integrate the 60s and 70s model by Humphrey Osmond to see if that could work maybe a little bit better than the current model. Also, there's outpatient medication-assisted treatments currently underway. So once those are done, it would be interesting to look at working maybe with an inpatient treatment center and doing an implementation study, seeing is it effective in an inpatient group, and can it maybe help people down the road once they're getting out of these inpatient treatment centers to avoid relapse. And lastly, another one could be following up Dr. Garland's study at the U, which would be looking at maybe individual therapy versus a group therapy intervention, maybe seeing if that added social support could play a role or lead to greater insights during the integration and follow-up. So that is it. That is my presentation. Here are my citations right here. And I'd like to thank the Intercollegiate Psychedelic Network for hosting this conference and allowing me to present. And I'd also like to thank everyone at my lab, CMind, for the wonderful work that they're all doing. And I'd like to thank all the researchers, clinicians, and people who are offering peer support to save lives and combat the rise in opioid use disorder. Thank you.